to Dr. GVK and the entire team. Indian diabetes phenotype, actually the first two talks have made my life very easy. Because, first dialogue was on remission. We know Indians have thin fat phenotype. Then we again saw very nice ectopic fat dialogue between Krishna and the team. So India is really the epicenter of diabetes, and most of our diabetes is undiagnosed. And what is very peculiar is that we are the world number 2, we may be the world number 1. We don't know that, but we are unique. We have a clinical phenotype for sure, and we have a lot of heterogeneity and clusters in that. We have different manifestations, we have cost and complications, access and adherence. So we are different, no question asked about it. Because we are Indians, we are Asian Indians, we definitely live within India, but we also understood our phenotype better because we started migrating 200 years back. First wave of migration occurred actually from the southern plate of Tamil Nadu to Singapore, south and east of Africa, Mauritius and Fiji and West Indies. That was the first wave of migration. That's where first we understood the Indian phenotype. Because it was the migrants who actually got that extra fat. Then the second wave of migration occurred in UK, Netherlands, Australia, Spain and Indonesia, where a lot of North Indians, Gujarati communities, Sindhi communities migrated. The third wave occurred in North America, where again, apart from Gujarati, Punjabis, a large Telugu population migrated. And then pretty much now Indians have migrated across the world. You can go to any part of the planet Earth and you will see Indians which have migrated. But another problem occurred within India. From tribes to villages to small towns to small cities to metros. So it was not just outside of India we saw migration, but we saw migration within our own country, within our own geography. And we can see that there's a large migrant population, say for example in Chennai. This hotel is basically owned by an Andhraite. And we can see a lot of people of Andhra Pradesh here. We see a lot of people from Kerala here. And a lot of prominent diabetologists here come with the lineage of either Andhra or Telangana or Kerala. So, we see migration across, and a very nice paper was put out on adiposity, type 2 diabetes and migration. What is central to us in our phenotype? If we pick up people coming for anything to our clinics, like primary care clinics, and Krishna was talking of small clinic research in another room, okay, you can see this was a site study we did from 8 states, 16,000 population, people visiting for any problem, cough, cold, fever. They had the twin epidemic of hypertension and diabetes. And most of them, 86% of them had truncal adiposity. So fundamentally you saw from a village to a town to a city, it was the truncal fat or the abdominal fat, which is waist circumference for women more than 80 centimeters and 90 centimeters for men. That actually is the typical thin fat Indian phenotype. So we are a global epicenter. Our phenotype comes because we have a very rapid economic development, urbanization, nutritional transition, and most of the diabetes on planet Earth type 2 is in our geographies. And we have challenges. We have resource limitations, we have a higher premature mortality and morbidity, we have socio-economic issues, and we are also seeing a second peak and a lot of young people with diabetes, not an old age disease. So diabetes in India compared to the Western literature is a disease of middle age and disease of the young, while if you go to the Western civilized countries, it is a disease of the aged. We see definitely much more stroke and kidney disease, and attitude of people at large to accept diabetes self-management is rather tough. Unfortunately, most of our research has focused on expensive new drugs which are unaffordable to a large mass. So our Asian Indian phenotype, is it genetic or is it environmental? Probably it's a little bit of both. Clearly we have a familial penetration. If your father and mother both have diabetes, it's 90% for type 2 diabetes. If one parent is diabetic, with type 2 diabetes, it's 70%. If it's one relative, it's 40%. The same may not hold true for type 1 diabetes. So clearly there is a familial preponderance to a garden variety type 2 diabetes. Is it environmental? Absolutely yes. We are sedentary, our physical activity has come down, And clearly we are getting more and more affluent. We are thin fat Indians, more fat, less muscle. I don't want to talk of that because the previous two dialogues clearly recognize that we have a lot of ectopic fat, particularly in the visceral area, and we are sarcopenic. But the first study came from New York. In the Brooklyn suburb of New York, Mary Ann Banerjee, who was a registrar that time to Professor Harold Leibowitz, who is about 90 now, did this study on normal people, Asian Indians of Indian, Bangladeshi and Pakistani origins. Predominantly they were taxi drivers, African Americans there living in New York, and Caucasians. And young people who had a normal BMI had a body fat percentage in the Asian Indian crowd 33%, while the African Americans and Caucasians were 26%. And they published this data in 1999. That was the first thing, and that clearly showed compared to African Americans or Caucasians, we have much more body fat. So in the non-obese Asian Indians, we have much more body fat, and that was the first phenotypic description. Of course, we have the YY paradox of the Yagnik and Yudkin, and we have this whole ectopic fat and obesity which has come in. But thin fat Indians, clearly we know is total fat, abdominal fat, less lean mass, skeletal mass, and clearly compared to the other ethnic groups. So for the same BMI, if you see three individuals here, we can clearly recognize that patient A is mostly of Asian Indian origin, while patient C is mostly of Caucasian origin. So it's quite easy to recognize it. And this is a new phase of malnutrition today. Low lean mass is present in all body weights, but a new malnutrition is sarcopenia. Low lean mass in Asians, and this is typical of Indians. Central adiposity, obesity at a lower BMI threshold, and clearly affluenza is something very clearly because we eat too much, we have excess calories, we're inactive, we are very urbanized, and across India, not just in south of India, we eat too much of carbs and too much of fat and too little proteins, whether we are diabetics or non-diabetics. And of course we are gadgetized in India, whether it's television, whether it's computer screens, whether it's our mobile phones, we are gadgetized, and we don't do non-exercise activity thermogenesis. We are not fidgety enough. We are very, very sedentary. And what is need? It is non-exercise activity thermogenesis, which is much more important to burn fuel than exercise. And it's very, very important to recognize that we have become more and more chair bound. If you see, typically a chair bound Indian has a NEAT of 300, a seated Indian has 700, somebody who is doing strenuous agrarian work is 2300. So what has happened to the modern India? The agrarian modern India had a NEAT, non-exercise activity thermogenesis of 2000 calories. That has dropped down to a sedentary Indian who is gadgetized to 700 kilocalories. So this is the biggest switch which has occurred, and which is why we need to build muscle, we need to exercise, and that's far more important beyond eating less. So we are clearly sarcopenic, we have more fat, less muscle, we have less muscle mass, we have mitochondrial issues also in our mitochondria because our ability, and from the Mayo Clinic, Dr. Nair publishes work, Asian Indians have an enhanced skeletal muscle mitochondrial capacity to produce ATP in association with severe insulin resistance. So clearly our phenotype is central obesity at a lower BMI threshold, and clearly we recognize that we are much more insulin resistant compared to white Caucasians. So clearly we have this phenotype, and when this was collated as South Asian or Asian phenotype, more abdominal or thin fat Indians, more insulin resistance and hyperinsulinemia, lot of inflammation, lower levels of adiponectin, and a typical dyslipidemia triad. Low HDL is the most common, followed by high triglycerides, followed by high levels of small dense LDL, and we are very susceptible to coronary artery disease. Also, we know that we are thin fat Indians, but from a pharmaceutical standpoint, we need lower doses. Our pharmacy student did this data, 7.5, 15 and 30 milligram of pioglitazone. We clearly recognized that 7.5 milligram can exactly give you the same A1C reduction compared to say 30 milligram without causing the adverse events of edema and weight gain. Similarly, if you look at the carbohydrate load, and this is true with any gliptin, but this was a registration trial for sitagliptin, clearly showed that Indians and Koreans, because they have a larger carbohydrate load, their A1C dropping on a gliptin is almost 1.3%, compared to Caucasians where it is 0.3 to 0.8%. So typically, if you see in the Western world, they have dismissed gliptins as mild drugs. While in our population, now that they are generic, we are seeing an excellent response because our load on the intestinal N and K cells is much more, and that is very, very evident. Obviously, we need Indian guidance and we need lower BMI cut points, and a lot of data has gone in developing guidance. Most of it is work in progress. It's evidence-based generation, and we need our cut points to be there. Beyond sarcopenia in our phenotype, another major feature in our diet is lack of fiber. Most of the modern foods which we are eating today are fibropenic, and we need to increase the fiber intake, and that doesn't need any effort. We need to increase dietary fiber. We need to have 25 to 40 grams of fiber per day. My final point is that we need to look at that we are a thin fat phenotype. We are Indian phenotype, but we are now into cluster medicine. Because type 2 diabetes is a heterogeneous disease, and clearly we see many clusters now. For example, Scandinavians describe some clusters, and now in India we have these clusters. The Scandinavian population had a severe autoimmune diabetes cluster, which is probably like a type 1 diabetes. So that if you remove that, we will see many more clusters. These clusters are based on age of diagnosis, BMI and waist circumference, A1C, simple lipid profile with triglycerides, HDL, and maybe a fasting and stimulated C-peptide. And what can be replicated and reproduced are some clusters like SIDD, MARD, IROD, and CRIDD. Let's look at all of them. So typically, as I told you, that this is our phenotype. This phenotype has evolved from lower age of onset of type 2 diabetes, lower threshold of BMI for type 2 diabetes, lower insulin levels or insulin resistance, rapid beta cell decline, lower adiponectin, which Krishna was alluding to, with a lot of gut microbial changes, typical dyslipidemia, low B12 and D3, low muscle mass, lot of inflammation, abdominal obesity and visceral fat, non-alcoholic fatty liver disease, and finally Dr. Yagnik's point of low birth weight and thin fat Indian phenotype in utero. So it's important to recognize that maternal nutrition is equally important. These are the classical clusters which we are now seeing. Most of them are, the most common cluster is the mild age-related diabetes. Second being the IROD and SIDD, which is severe insulin resistant deficient diabetes and insulin resistant obese diabetics. So if you look at MARD and IROD, it's all about insulin resistance. If you see the CIRD, which is 10% or 12%, it's a much more severe variant. We get beta cell dysfunction and insulin resistance both together. And this is work in progress. We need to study these clusters and their prevalence of complications, micro and macrovascular, whether it's chronic kidney disease, nephropathy, retinopathy, so on and so forth. So we need to cluster. We need to subclassify diabetics into different subtypes, plan treatments based on that, predict prognosis, prevent complications. And we are moving towards precision care. And definitely this cluster medicine has become a standard of care in the times to come. My final take-home points are that we are working towards identifying people at risk and pre-disease. I think most of us have become experts in recognizing complications and treating end-stage disease. And we need to move towards identifying people at risk and pre-disease. And the right term is adiposopathy. BMI is a very poor measure of individuals' adipose-related burden. It's a fat quantity, quality, and location which matters. And therefore, I don't like to use the word obesity at all. It is adiposopathy, which is more important. It's a pathogenic driver, and that's why I'm happy that Dr. GVK thought I should talk after that debate on ectopic fat. And therefore, the goals of treatments and outcomes differ by the disease stage. And we need a holistic approach. We should move beyond a glucocentric approach. We should look at weight, cardiocentricity, obesity, cardiovascular disease, and look at a typical wheel. And we need to adapt guidance. So when we see in India phenotype of a patient, we see the full spectrum. We see malnourished, we see lean, we see thin built and central obese, we see normal weight, normal build, we see overweight, obese and morbidly obese. All the 7 phenotypes we see in our population. And that is why all the international guidelines are not suitable for India. We still see population which is lean and non-obese in diabetic population. That's number 1. 20 to 30% have BMI less than 25. And 10 to 20% will have a body fat in the non-obese range. But what you need to recognize is a small 5% will have a BMI less than 19 residing in rural and hilly areas. People between 25 and 19 may still have intra-abdominal fat. And metformin may still work on them. But below 19 or 20 it may not work. So you need to recognize that fact very clearly. Secondly, we still see ketosis in people with type 2 diabetes. Ketosis doesn't mean type 1 diabetes, particularly in these seasons of summer which we see. Severe infections, major surgeries, steroids, major trauma. And our patients interrupt treatment. Minute they feel that glucose becomes normal, they just stop their medication. They think that they're cured of diabetes. And then they come back to us with severe ketosis and hyperglycemia. And they often eat or drink a lot of beverages. So ketosis can present with type 2 diabetes. In fact, 5 to 15% of our population presents with ketosis. So we have an original ketosis variant of type 2 diabetes seen in sub-Saharan Africa, but it's definitely there in our Indian population. And finally, most global guidelines don't embrace the carb content which Indians and Chinese eat and eliminate alpha glucosidase inhibitors, which I feel is little unfair. And therefore it's important to recognize that they are still a part of our recommendations. And I'm happy that agencies like RSAGI, which Dr. Makkad leads, has now incorporated them in a big way. Final point, one size does not fit all. Yes, glucose control is important, but patient safety is equally important and treatment has to be individualized. And therefore there is a call for action. And though people don't like the word pre-diabetes, WHO says you should call it, intermittent hyperglycemia. Okay, I think it's important to have early action. And therefore it's important that we are all harbingers and brand ambassadors for prevention of diabetes. We are living in a digitalized world. And in a digitalized world, my mantra is eat slowly. Don't contract your pancreas very fast. Eat less. Eat on time. Eat the right food. Have a large breakfast, moderate lunch, light dinner. Use the circadian clock to your advantage. Do physical activity. Try to encourage NEAT. And beyond that, do some yoga, sleep well, sleep on time. It's very, very important to recognize that. The equally important thing is, we need to do an hour of digital detox every day. It's very important to do a digital detox every day. And it's important that it's not only about health. It's important to do health and happiness together. And my final take-home point is again going on the fat and fit story. We need to be fit and we need to build a muscle. And that comes through exercise and by eating less. And the final message is, time is muscle. Time is muscle. Build muscle. Let's not waste muscles. Activate them with exercise. Thank you so much, GVK, for allowing me to talk on something which I love to talk.